Well, good morning, everybody. It's a real pleasure to be here. I want to thank Mark Allen and the ever-organizing committee of the GTC for the invitation. And we're going to talk about mesothelioma. And we heard reference to a wrestling match, but indeed, I think the wrestling is over, and we as surgeons need to be thinking about the next step based on what we've learned over a number of years. And what we've learned really is nothing new. It's all about the solid tumor paradigm, which is set in stone in a number of solid tumors. Local control and cytoreduction is in the realm of the surgeon. That's what we do, whether you're doing breast surgery, whether you're doing colon surgery, whatever it happens to be. You're cytoreducing. And what we've done, I think, together over the last 2 decades is to develop at least 2 operations, and there's others that are being fashioned, but 2 operations that can achieve cytoreduction based on stage, tumor volume, and a lot of other, several other factors, cardiovascular status, etc. Surgeons used to do the Halsted mastectomy thinking that they removed all of the breast cancer cells, right? Then we learned that that's not the case. And local cytoreduction is the primary goal, and systemic control of micrometastases is the real challenge. And I want to just sort of start off by focusing us on the idea of proceeding to the next step. So there's a number of ways that we have seen in lung cancer as well as other malignancies that have brought some new elements or new tools in cytoreduction, radiation therapy, of course, ablative therapies. And then when it comes to control of micrometastatic disease, we have to focus our efforts on tools or adjuvant treatments that hit or preemptively strike the most common form of micrometastatic recurrence. So in lung cancer, we're giving adjuvant chemotherapy because systemic metastases for the majority of patients is the end game killer. In mesothelioma, things are different. So when it comes to figuring out what we use, surgical margins, the presence or absence of hematogenous disease, which occurs in about 10% of mesothelioma cases, and then of course lymphangitic spread, which is very dependent upon what cell type you're talking about. Chemotherapy, biologics, targeted therapies, as in other malignancies, we're moving forward in mesothelioma. But as I mentioned, the primary approach is, I believe, preemptive therapies. So we were talking about the wrestling match, and I think the wrestling match is over. What we need to achieve in mesothelioma for the majority of patients where it's possible is at what we call an MCR. We've all been talking about this for years, macroscopic complete resection. It's the goal of mesothelioma surgery, and I think particularly when you don't adjust for tumor volume, which is the primary driver we now know of survival, then you can get a little confused. But the bottom line is that macroscopic complete resection by either procedure is indeed, the goal. The margins will differ between PD and EPP, simply because every surface at risk, or I should say surfaces retained in the patient after the tumor is removed, will indeed, increase the risk. So when you leave in the lung, particularly if you get into the lobar fissures, you've got a lot more tissue where potential recurrence can occur. But distribution and tumor biology, particularly as I mentioned, tumor volume, along with cell type, I think direct the therapy. Extrapleural pneumonectomy, morbidity 25% if you exclude atrial fibrillation. Mortality now is anywhere from 3 to probably 10%, my last review a couple weeks ago. In some situations, particularly when you have invasion into the segmental fissures, it's the best form of achieving MCR. And there is more data recently about external beam radiotherapy and our problem with local control, so there is a little bit sort of a pushback that maybe having an empty chest is an advantage. This is what we've done at the Brigham, and okay, so the magenta here is the pleurectomy decortication, the yellow tan is EPP, and as you can see, the majority of the cases we've had through the years, particularly in our early experience, were extrapleural pneumonectomy. These were the electricians, the ship workers, shipbuilders with large volume disease. And as time's gone on, we're seeing patients with earlier disease. We've seen a shift somewhat to epithelial cell type. And so we would recommend, again, achieving an MCR. Obviously, if you can retain the lung, particularly in a younger patient or in an older patient, it's a great thing to do. I mentioned sarcomatoid and mixed being different. It certainly is much more aggressive. And interestingly enough, we've looked at a large number of patients, particularly the pure sarcomatoids. I think there was one that had nodal involvement. So genetically it's different. Nodal disease, obviously then is not the prognostic marker that it would be an epithelial disease, which is why, you know, I've written a few things and talked up the idea of a separate staging system. So we think they should be broken up, particularly when you're going to report on your therapeutic efficacy, because they're really two very different things, like small cell and non-small cell lung cancer. And again, as I mentioned, different staging systems. Here's the epithelioid, cuboidal cells with these palisades, and here's the biphasic, you know, swirling cells, sarcomatous features. Here's a mixed tumor, here's some epithelioid, but this is really a bad actor, as I think most of us know. So I mentioned that we were talking about separate staging systems. All right, so this is our data broken down into, of only epithelial cases, 354, and we modified the TNM staging system, which is reported in this paper in Cancer a couple years ago. But basically you can see that when you begin to look at specific cell type staging, I think you get a much more accurate idea as to which patients should be selected for operative therapy. These are the sort of standard ways that I think have evolved through the years of preoperatively selecting patients. We as surgeons can improve the outcome of our surgery by having better surgery, better chemo, better adjuvant treatment, but also patient selection. You know, the more accurately we select patients who will benefit from aggressive therapy, the better our results will be in that group. And the more people we will save from a useless thoracotomy or other aggressive treatment. So N2 node status, we routinely do mediastinoscopy or EBUS. Clinical stage, of course, ascites. I know Joe Friedberg and some folks out there do routine laparoscopy. We don't unless we see ascites on CT scan. But patient selection criteria have evolved. Now, what we've been looking for, because pathologic stage is just that, it's post-resectional stage, right? What we'd all like to have is to be able, from our office, to select a patient who should have aggressive treatment. And we have put together a risk stratification that allows for the use of tumor volume, which, as Harvey Pass reported many years ago, is the most important, I think, predictor. Gender, with females doing better, and anemia, interestingly enough, suggesting a sort of hormonal activity of the tumor, which we know in lung cancer and carcinoid tumors is also a sign of an aggressive malignancy. So here we have risk 1 patients, low volume, male or female. The women can have any type of anemia and males can't. And as you move down to risk 2 and risk 3, we see tumor volume jumping in greater than 500 cc's, males grade 0, any volume, male grade 1 anemia, and it's really the tumor volume here that's driving things. The risk 3 patients are males, anemic, women who have higher tumor volume with some anemia. So this is something you can do in the office, and this is the survival stratification by risk group. This is in the journal Thoracic Oncology, but you can see here the risk 1 patients, 35-month median survival, risk 2 in the red, 12 months, and risk 3, 5 months. So if we can eliminate risk 3 from our operative approach, and we can maybe more appropriately target protocol-wise the risk 2 groups, I think we will save a number of patients. A useless approach, and those who do get surgery will be more likely to benefit. Now, this paper is being republished and updated. This is from '97, and Beth Baldini has just looked, I think, at 300 and some cases. And this was the patterns of failure paper that really pushed us into improving local regional treatment. Isolated distant failure was uncommon. Future strategy should investigate methods of enhancing local control. We wanted to extend the surgical margin after quantifying that. Certainly, I think that's most of our clinical impressions, is that the disease, is a local problem for the duration. We know that we can get drug delivery by direct diffusion. Very powerful chemical principle, high concentration of a drug or any substance going to a low concentration. In this case, the drug is passing through the tissues to the plasma and the capillaries, which is exactly where we want it to go. This is what we call the pharmacokinetic advantage. The systemic concentration, intracavitary to systemic concentration gradient. So we've done a number of phase 1-2 trials of MCR. We give a cytoprotective agent which removes all the platinum, in this case sodium thiosulfate, at the end of the lavage, and amifostine protects normal cells. So that allows us to get our concentration up, build on that gradient concept, and improve our advantage. So it's hyperthermic because, of course, that's been shown to improve overall efficacy of a number of different chemo agents and dose escalation. This is sort of a summary of our work in the use of platinum, and we presented this a couple of years ago. Allows us, what we wanted to do was to compare those receiving heated intraoperative chemotherapy or HIOC versus those who did not. We looked at the risk 1 patients that I just mentioned to you, epithelial subtype only. They had to have had a MCR, and they had to meet the study criteria with a minimum follow-up of 27 months. They were all risk 1, as I mentioned to you, epithelial, less than 500 cc's, and no anemia. And this is the time to recurrence of the risk 1 patients. The red here are those who got intraoperative heated chemotherapy. That's a 24% 5-year survival, which if you would have told, I think, any one of us that 15 years ago, we probably wouldn't have believed it could happen. But the control group had a 6%, 12-month median survival. So we see almost a little more than doubling. Yeah, I'm sorry, this was time to recurrence, not survival. This is overall survival. 38% 5-year survival in the group getting HIOC of the risk 1 patients. Now, at 38%, we're beginning to surpass some of our other bad actors like Pancoast tumors, maybe all comers with esophageal cancer. So I think you can see we're making progress, of course, in selected groups, just like with lung cancer. We select a subtype of a subtype, MEAD, EBUS negative, et cetera, T1, T2 lesions, and we go down to the subset analysis, really, which is what this is. But overall survival, at least in this, now it's got problems, it's historic, it's not a prospective randomized trial, which is pretty difficult to do, but nevertheless, over 100 patients. So we feel that this new approach with an MCR extends time to recurrence, overall survival, and particularly, I didn't show you the data, but in patients with lymph node positive disease at the time of resection, there's an even broader divergence between those who got intraoperative chemotherapy and those who didn't. The other groups that seem to benefit are those patients who got outback chemotherapy, adjuvant chemo. So we now recommend that. And the patients with biphasic histology on final path, interestingly enough, had a divergence between those who got chemo and those who didn't in a positive way. So we think that HIOC is a positive thing, and I'll just quickly move synergy. We want to look at now doublets, since we have a platform, we have a pump, we have a team, we can do the thing, we can take an hour out and get the surgery done, and then the chemo. So we wanted to look at a second drug with compatibility, no overlapping toxicity, separate mechanisms of action, favorable intracavitary pharmacokinetics. So we looked at gemcitabine. Same drill, MCR by EPP or pleurectomy, amifostine, intracavitary platinum at 175, stable dose, and then an escalation of gemcitabine. Accrual 141 patients over this four-year period. 100 patients underwent EPP or PD. This is a prospective IRB-approved trial. Median age was 65. 21% were women, which is something we keep seeing more and more of, a higher percentage of women. It used to be virtually 0. 61% were epithelial. MCR was achieved by EPP in 59 and by PD in 41. So the mortality of EPP was 3.4%. The PD was 0. We had some renal toxicity. Our dose-limiting toxicity in gemcitabine was leukopenia in 2 patients. So we settled on a maximal tolerated dose to run out a number of patients, 1,000 milligrams of gemcitabine and 175 milligrams of platinum. And when we add gemcitabine in the epithelial histology, you can see that we have bumped the early, there's not very many patients out this way, but we've bumped the survival curve, so we're basically, I think, pretty enthusiastic about this. This is in the epithelial group. The non-epithelial group, there's really not much difference when you add gemcitabine. Now, the next idea is to add a third drug, which may be Alimta, because, you know, the big winners, CHOP and MOP and CAP, have all been triple to quadruple drugs. That's where chemo seems to be the most effective in a variety of malignancies. So we're headed in that direction. This is just I want to just end by talking about, I think, another subgroup that's a big winner. This is a study of those patients who survived 3 years. We looked at nothing until 3 years, then we followed them out, all right? Men and women. We wanted to see, if you will, there's a seed soil theory of any cancer, right? There's the soil, that's the body, you know, the normal tissues, and then there's the bad seed, if you will, the cancer. My thought here was not just to study so much the cancer, but study actually the soil. And could it be something in the soil that rendered these patients more likely to be long-term survivors? And this is the only slide I'm going to show you, which is, this is males, and the 2 survival curves are those patients who were younger than the median age of 53 or 54, I think, and those that were older. And you can see there's no difference in survival in males, but broken down by age. Women, however, if you look at the women who were essentially postmenopausal, and we went back and did that data analysis, and those who were premenopausal, you can see that the premenopausal women treated aggressively with surgery, chemotherapy, had a 90-month median survival. Now, you know, there's no gynecologist in the audience, but the difference here is estrogen, of course, estrogen beta receptors. We've now found on about 80% of male tumors and a relatively high percentage of female tumors with our genomic approach. So this would suggest that potentially oral, let's say Premarin or something like that, may be helpful in mesothelioma. So let me just run through what I think the established indications are that I think should prompt a real serious consideration. Women 56 and younger, risk 1 patients, and those patients who have very minimal disease, which is, we've identified a group with less than 100 cc's of tumor volume. They have a 92% 5-year survival. No involvement of the fissures, hemoglobin normal. Those are patients, I think, who should be aggressively treated. Where are we going? Targeted therapies, of course. We are trying now in our group to identify mutational profiles with transcriptome, whole genome sequencing. We're looking for particular pathways we can target. And this is just a paper we published several years ago on the transcriptome, high throughput sequencing. Found 13 particularly interesting mutations. We published the genome of mesothelioma, again looking for it looks like there's going to be about 15 or so buckets of mutations clustered together in mesothelioma. So each one of those mutations is an aberrant pathway. So if we can find pathway inhibitors, sort of giving a cocktail of biologic targeted therapy, I think that's where we're going. At least that's our strategy. So we have a drug now, this FAK inhibitor, VS6063. It's a pill. We're giving it pre-op, following with PET scans. It's really our first foray into targeted treatment. And conclusion, MCR is where it's at. Local regional failure is the problem. These are the basics. HIOC appears to be helpful. Directions will involve, as I mentioned, novel agents, targeted therapies, mutational profile of individual patients. That's the thrust of our current research. And we're looking for multi-agent combinations to approach intraoperative treatment. Thanks a lot. Really great to see you guys.